Bismillahirrahmanirrahim. My name is Sayyid Muneeb Haider, and today I am here to present you all exotic group presentation, including the title Clinical Management of an Ectopic Egg in African Grey Parrot. First of all, let's introduce the case. A 13-year-old female African grey parrot was brought in for ventral feather loss and unusual nesting behavior. The bird was also acting very territorial, even aggressive, but had a normal appetite. The signs indicated she was in a reproductive phase despite no known breeding history. Proceeding further, we initiated the initial exam. First of all, we sedated the parrot for a thorough examination. She was alert and in a good body condition. We noted a brood patch, an enlargement vent, and widening of the pelvic bones, all typical of recent egg production. Blood test showed low white cells but high calcium and muscle enzymes, consistent with egg lying. We took x-rays and found one normally formed egg in the right side of her coelomic cavity. Since there was a formed egg, we expected her to lay it soon. The bird went home with a nest box and the owner was told to watch for lying. We did not see signs of dystocia in the initial examination. After a 1 week checkup, the bird did not lay an egg in 7 days. She remained bright with no straining or distress, and her nesting behavior had stopped. We repeated blood tests, which were now normal, and x rays were also normal. The new radiographs showed the egg had flipped end to end by 180 degrees, something that should not happen. Now comes the actual point. Diagnosis of ectopic egg. We did an ultrasound which showed that the egg floating in the coelom separate from the oviduct. This confirmed it was an ectopic egg, means free inside the body, as I discussed. Proceeding further, here comes the treatment decision. Because the egg was free, we decided not to try hormone induction of line or any local manipulation, as these methods work only for stuck eggs. Instead of this, we planned surgery. We gave leuprolide acetate, a GnRH agonist, to suppress the parrot's ovarian activity, reducing blood flow to the areas and making surgery safer. The bird was also given an antifungal medication as a precaution during her hospital stay. Proceeding further towards the surgical intervention. 2 weeks later, under anesthesia, pre-medication with midazolam and butorphanol, isoflurane gas was performed a ventral midline ciliotmy. Inside, we found a white mineralized egg floating free in the coelom. We carefully removed it with gentle pressure and cotton applicators. The egg had a normal shell but no yolk inside. We checked the oviduct and found it to be normal. There was no infection of tissue damage from the egg. We closed the incision routinely and the parrot recovered from anesthesia without any complications. As our case is approaching, now we are heading towards the post-operative care. After surgery, we treated the bird with azithromycin and meloxicam, and we continued the terbinafine. 3 days post-op, we gave a second dose of leuprolide to further suppress her reproductive hormones. We advised the owner on long-term management, feed a balanced diet, avoid extra treats, and encourage egg laying. Limit petting to the head and neck only, and block access to potential nesting sites around the house. After the completion of the case, a recheck was performed 8 months later. The parrot had no signs of retained egg or reproductive problems on exam and x-rays. Over a year later, the owner reported no return of the previous behavior or any new egg laying. The bird has been doing well with no complications.